It's usually what it takes. I guess we're probably ready to start. It's 12:05. I guess I can take this. You guys go with it. Just do maskless, so I'm not shouting as loud. All right. I don't know if I'm breaking a protocol here, but I'll get a nasty email later. But so I'm Sean Rice. I'm one of the newer faculty. I've met some people in this room, obviously, but not everyone. I've been here for about 1.5 years or so, but first time I've lectured, I believe, for residents. I've talked to some of the fellows and some of the people interested in GI in our conferences there. But today we'll talk about gastroparesis and just to touch on intestinal motility disorders. This is a pretty common entity. We'll talk a little bit about the pathophysiology and some of the treatments and kind of what you're really thinking of in the internal medicine level, and then even to the next level when you're kind of thinking of the next like fellow level type stuff. So it's important to note the GI tract is actually fairly complex. It has its own nervous system. It's strictly modulated by the central nervous system, and I think that gets forgotten sometimes. So that this can actually be, you can have dysfunction at multiple different levels, both in the central or primarily in the nervous system of the GI tract. So the neural plexuses are mainly modulated by parasympathetic neurons, and the enteric nervous system has a variety of different cells and systems that function on it. The diagram on the right is sort of complex, but it gives you an idea essentially of the neurons and how it's modulating into the enteric nervous system. For the most part, knowing exactly which cell is functioning and where is probably not going to be all that important for you guys and for your boards. And I doubt MixHap would probably ask questions about that. Now, what is driving all this stuff is the migrating motor complex. So this is called the MMC. It gets a little complex, and this is unfortunately not super well understood. Yeah, it's kind of strange in GI. There's a lot of complexities that we don't quite know as well. And this is one of those things. We know there's 3 phases. There's quiescence, an intermittent phase, and then actually one that we're doing something in, and that's the activity front. So that's essentially where things are kind of hanging out in the first 2 phases. Phase 3 is kind of just like the clearing phase. Like things have not moved through. This is, again, in the fasting state. This all happens when we're ready to start moving things through. This is just a nice power contraction through the GI tract. So it's inhibited by meals. Like I mentioned, it's only in the fasting state that this is happening. So this is if you were to do manometry or manometric studies where you're measuring pressure waves, and this is what you'd see. This is the actual phase 3 contraction. So phase 1 and 2 are not denoted here. But so you'll see in the gastric body, and as you move distally in the GI tract to the antrum, the duodenum, you see a self-propagated pressure wave that's going through. So this actually is occurring. And you can imagine that if there's any dysfunction at any point in the nervous system or in the muscles themselves, that you could have problems with the stomach emptying or and the resultant symptom complex that you might see in gastroparesis. So it's a very carefully coordinated system of relaxation and contraction. So that's also important. It's not just squeezing, it's also relaxing in the GI tract. So normally, it's important that the fundus in the body and the antrum, they actually accommodate. So they're relaxing response to a meal. This is vaguely mediated. So you eat, you relax, you accommodate, and you can have problems and symptoms that result when that's actually impaired. The antrum, the pylorus, they actually, so I'm not sure gastric anatomy if you're all that familiar. So when you get down to the antrum, which is the part of the stomach that connects through the pyloric channel to the duodenum, or the first part of the small intestine, that actually contracts. And for those of you that have seen EGDs, if you've come in the GI lab and watched, we go down there and we'll actually take a look, and you'll actually see the pyloric channel is closed. Like it's functionally closed, physically closed by the muscles. And it can be kind of annoying when you're trying to learn endoscopy because you can't get the scope through there, and your attending is watching you and is like judging you and saying like, hey, I can't get into the small intestine. But eventually that muscle does open and you can pass the scope through. But that is actually an important function. It's not just there for no reason. It actually serves as a narrowing for the stomach to squeeze against and triturate and break down the physical particle, or essentially the large food particles, into a digestible particle size. So again, this is, it gets a little bit more complex, but essentially with solids, this is really important. In liquids, not as much. Liquids kind of behave without too much necessity of this trituration process. So I like to say that gastric motility is super well understood, like it is in the heart, but it's just not. You know, obviously we have a whole specialty in cardiology and electrophysiology that focuses on, hey, we know where this starts, we know how it propagates, we know the dysfunctions. We don't really know it to that degree in the stomach. We do know there is a pacemaker. It's somewhere in the proximal part of the stomach, but we don't exactly know how it functions or how to modulate it. But it does actually have impact on gastric motility. So there's a variety of different cell types that kind of propagate this, this complex in the electrical circuit through the stomach. And this actually, we find this to be true, and we find the pathology more when people have had surgeries or interventions where they have vagotomy. So when you actually transect, or purposefully or not purposefully, that you'll actually have complications in gastric motility. So we know that people that, you know, if you had a surgery and actually had an iatrogenic injury to the vagus nerve, for whatever surgery that may be, you actually might need a pyloroplasty, because they actually cannot relax that muscle in the pyloric channel. So essentially you have a gastric outlet obstruction as a result. So the kinetics, if you're thinking about the motility itself, so this seems like a graph you might see on your board exam or something like that, where it says like, hey, interpret this. Like, you're like, I have no idea what this is, but you need to interpret this image and answer questions on it. But what this is really showing you is that it's kind of a, essentially the phases which you're emptying. The liquids at the bottom of this curve here they kind of empty without much difficulty. But the solid leg has a lag phase. It takes a little while for things to start like breaking down, and then you'll see it slow, and then an actual increase in the slope of that curve as it empties. And so if you think about how liquids empty, the half-life for liquids is about 20 to 30 minutes. And for those of you who have seen procedural specialties, anesthesia requires that you have clear liquids out of your system, or no sooner than 2 to 4 hours before. The reason for that is because 4 to 5 half-lives get you your 2 to 3 hours to clear all of your liquids out of your stomach. For solids, it's actually a lot longer. Usually anesthesia would say we need 8 hours for solid intake. And that's the reason why, is because it's much slower for emptying. And that's the reason why it's theoretical. There are some, there are some holes in the anesthesia reasons, but this is why those things actually exist, and why we actually think we have to hold off. So let's actually get to like clinically, that was like, you guys are probably like, I don't care about any of that stuff you just said, but let's talk to what functionally matters for you, and you're in your clinic, and you're and sometimes in the wards where this is gastroparesis is kind of thrown around quite a lot. But I think it's always important to know how a normal stomach functions, why it functions, and then what can go wrong with it. And this is kind of what we'll focus on here. So this table here shows kind of the different things that can affect gastric motility. So it's not just, it's easy to say this is gastroparesis, but you got to think as internal medicine doctors, there's a variety of different things that can affect that, whether it's a systemic or rheumatologic condition or a primary neurologic condition. We just reviewed that there are muscle components and neurologic components to this. So you can imagine anything that affects those different systems would affect the way your stomach, or really even your intestine, empty. So you go farther in the chart, perineoplastic syndromes, amyloid would be an important concept. Idiopathic, you probably, for many disease spectrums outside of GI, and idiopathic is usually a very common cause. You just don't know. And unfortunately, idiopathic gastroparesis specifically is probably the most common form of it. We really don't know what causes it in most cases. So I'll have some random questions that are scattered through here. I think these are probably doable. This is actually taken out of our review for GI specifically. It's called DDCEP. But these are probably, I took out the more complex ones that I don't think would be maybe to your knowledge level. So what's true about gastroparesis? You guys can read these slow. I'll just read them out loud and just kind of think about it. I'm not going to pick on anyone individually, but whatever you guys think. But so choice A, diabetes is currently the most common cause. Well, I kind of told you that's not, so you can rule that one out. So choice B, severity of symptoms has been correlated with degree of gastric emptying. So that's essentially saying, gosh, your stomach doesn't empty at all. You're going to feel terrible. Choice C is early satiety and postprandial fullness correlate better than bloating and pain. And D is scintigraphic emptying of solids should not be done in a diabetic with a blood glucose of 190. I'll just work through this for you, actually. So the choice D seems like, if you're doing test taking skills here, choice D seems very specific. Like, I have no idea what the blood glucose is supposed to be if you're taking a test. Like, that seems like that's probably not right. Choice B, choice A we eliminated already because I already told you. Choice B, severity of symptoms is not really necessarily associated. So you can have horribly like paralyzed stomach and actually not have that severe symptoms, and vice versa. You can have like pretty mild gastric dysmotility and just feel terrible. So this is common a lot in the GI tract, even for like inflammatory bowel disease. You can have rip-roaring disease process and have minimal symptoms, or vice versa. So it's not clear why that is, but they don't necessarily correlate. The things that you see is what you should really tip you guys off when you're seeing someone in clinic is early satiety and postprandial fullness. And so we see this a lot in clinic. Someone will come in, and if you're in your internal medicine clinic and say, hey, I'm just getting full early, it's usually after I eat. That is an important thing to ask. So, when you're thinking about either referring to a specialist or just when to fire on a gastric emptying study, those are your two triggers that say, hey, maybe this is going on. So gastroparesis itself. So it's pretty common, 2.4 per 100,000 person years in men and 9.8 per 100,000 in women. For prevalence, type 1 diabetes is 4.6% of people, and type 2 is 1.3%. This figure on the right kind of shows what we talked about in a graphical format, but really the point of this is to show you that there's different reasons for it. There's central nervous system processes, there's primary myopathic processes. You also got to think about infiltrative processes, medications, and this is just maybe a nice way to organize your thoughts outside of a table format. Just kind of knowing that, hey, we can have this entity for a variety of reasons. And so kind of going back, why you have this dysmotility is really functionally because what you need is a nice contraction and relaxation happening simultaneously. And when that's disrupted for whatever reason, it doesn't happen, you're going to have delayed gastric transit. The way they word that is lack of anteroduodenal motor coordination. That's the very distal part of your stomach. So essentially you have a stomach that doesn't squeeze very well, and you have a distal stomach that doesn't relax very well. And so those are two things working against you. You cannot digest solids very well. So you get nauseated, you don't feel very well. So these are the clues. Again, in your clinic, this is what people are going to talk about. Now, I will say that these are not necessarily specific for delayed gastric emptying. I think this is pretty much every one of my clinic patients, and GI clinic is one of these symptoms is almost 95% of the patients I see. It doesn't necessarily mean you have gastroparesis, but it can be a clue to what's going on. So what do you do about it? So if they're having these symptoms, I mean, this is like very common reason we see them in clinic, and EGD is reasonable really to look at the gastric outlet. So look in that pyloric channel. There's a lot of NSAIDs in this area. And so I'm from Ohio originally. BC Potters and Goody Potters weren't a thing there. I'd never heard of that until I did my residency in Nashville. And that was when, I think it was my first get together session, just our first training session. They made it a point to tell everyone that what a BC Potter and what a Goody Potter was, because I had no clue. And I'm glad they did, because those things are super strong. And the reason why I bring that up is because peptic ulcer disease is probably one of the most common causes. You'll see just inflammatory changes, peptic ulcers, and subsequent stricturing as a result. So that's why you do this test, is to make sure that there's not an obvious mechanical obstruction. And then at some point you want to look at the small bowel, make sure there's nothing distally. So a CT enterography or an MR enterography, or if you just want to do x-rays, you can get a small bowel study where they swallow contrast and take x-rays throughout. The mainstay, you guys know this, the gastric emptying study. What are we doing with this? Essentially, I tell people you're eating like an egg. Essentially, it's like a low-fat egg consistency meal. And then they just take measurements of the percentage of gastric emptying over a course of 4 hours. If you see an option, I don't think we have it here, but if someone orders a 2-hour test, I don't put any stock into it. It's not super helpful. You really want a 4-hour test to look to see if there's any level of dysmotility. Now, it's annoying to the patient because it takes 4 hours to do this test, but but it is helpful. If we want to get real specific with it, there are wireless motility capsules. We don't do that here. I don't know if anywhere in Tennessee actually does that. We didn't do it where I trained. I know UNC specializes in motility. They do it there, and some other places offer it at certain tertiary centers. But this is essentially, if you've ever heard of a wireless capsule endoscopy where you swallow a pill, instead of just taking videos, in these particular cases, it does measure manometric pressures throughout. So you can actually see kind of those scintigraphics, or not the scintigraphic, but the squeeze pressures that we saw earlier. This can get this and generate for the entire small intestine. But clinically, whether it's really helpful or not, it's debatable. It's kind of a fun thing that someone invented and said we should try this, but the clinical application is maybe not all that helpful in most cases. So we talked about most of this already. Idiopathic is about 50% of gastroparesis causes. Diabetes making up the majority, and of the things that we know, diabetes is the most common when you can actually rule it out. Viral. Normally, not sure if you guys have ever experienced this. I've personally experienced a post-viral gastroparesis. It's terrible. It can last for months. It usually does resolve in a year. And so I do feel for our patients. I understand it's not comfortable to not be able to eat. You just don't feel very well. One of the things that's important too, historically, you're talking to your patient. Surgically, if they've had a major abdominal or even a thoracic surgery, anytime you think there might have been some compromise to the vagus nerve, you could consider that as a cause or a etiology of delayed gastric emptying. One of the things that we do a lot is AFib ablations. So not super common. If someone has an AFib ablation, it's possible that you did have damage to the vagus nerve, particularly if you have new onset of symptoms after a cardiac intervention. So just keep that in mind. Our own interventions that we do, I've never seen this, at least that I know of, at least that I've caused. Maybe I have and I just didn't know it, but like sclerotherapy or Botox injections that we do for achalasia in the esophagus. Again, the vagus nerve is coursing down in the area. You can have some damage that way. So kind of think these are the things I really think about. There's other things, but medications I should also comment on. I get a lot of referrals for people with nausea, vomiting, concern for gastroparesis, and it's someone who has diabetes and they just got put on a medication that essentially delays gastric emptying. That is a common mechanism for some of our oral diabetes medications. Like we did that. That was the whole point of that drug. Like we delay gastric emptying with some of our medications, and I'll get to that. So the neurologic diseases. So we'll see this if you have a patient with Parkinson's or MS or some other primary neurologic disease. This is not an uncommon thing that we'll see. So it's just something to come in mind. If really knowing and understanding someone's history is important before you start saying, "Oh, this is just idiopathic. We don't know what to do." It's probably what's going on. So we talked about most of the secondary workup from imaging and scoping, but other things to get are listed here. I mean, you should get check their glucose levels. You can check their just basic labs. This is probably more of an advanced level question, probably for GI specific, but you can have paraneoplastic syndromes that do this, and those antibodies there, the anti-WHO antibody is important to know. The picture that's here, so I don't know if you guys have ever heard of flip technology before. This is an emerging GI technology where you can actually measure pressure. You essentially inflate a balloon and it measures the pressure and squeeze. We do this in the esophagus, but you can also do it at the pyloric channel. And this colored picture here, I don't know if I have, can you see this? This colored picture here will actually show the different strength and pressure that you'll get. And it can detect actually abnormalities. This can actually, when you give you pressure measurements, you can figure out if it's a myopathic, which would have disordered squeeze pressures, versus neuropathic potentially, where you're actually seeing reduced frequency of contractions. So those will give you clues. It's not regularly used for this, but it can be done. And again, probably we don't do it here. It would be more of a tertiary center referral. This is not very important, honestly. This is tachycardia. So this is just, I just thought it was kind of cool. You could do essentially the equivalent of an EKG on the stomach. The clinical importance of this is minimal. I've never seen this actually. It's possible, but I don't know whether you do anything about it. I just figured I'd show you what an EKG in the stomach looks like. So this is a question. I'll read it out loud. 78-year-old man, a history of Parkinson's and C. diff. He has epigastric pain, early satiety, and postprandial fullness. We got our buzzwords here. So now we're thinking in our head, is this gastroparesis? Remember, on your board exam, it's no particular order, right? It's not like I'm doing GI and then cardiology. It's like they just throw you random questions. So you have to be kind of ready for anything. So now you're doing your CGI question, clear it's a GI question on your boards. They have these buzzwords. Okay, I'm thinking maybe there's some disordered motility. He's had severe symptoms. He gets an upper endoscopy, which shows retained food in the stomach. That's another clue, despite fasting for 12 hours. So remember, I told you should only take 4 hours for liquids and 8 hours or less for stomach or for solids. So something weird is going on here. And it shows that a gastric emptying study shows 52% of meals at 4 hours. So I didn't tell you the absolute thresholds yet, but anything more than 10% at 4 hours left in the stomach is abnormal. So you're supposed to clear 90% of your stomach after 4 hours of solids. So the question is, what should we do with this person? This question is a little nuanced. It's a good question. It's a more of a, what am I thinking and how do I trick the test taker? But this is what they add in Mixapp and your boards. This is how they ask questions. And a lot of the way you can get through this, you can eliminate stuff. So essentially, this is painting a picture of an old man. Maybe that's not the right way to say it. An elderly, more mature man. He's in his 70s with this, the listed history. The test writers will list the history for a reason. They don't just put random stuff up there like, we'll write this one liner with like a million things on there. They're picking things purposely for you on these tests to show you what's important. So this guy has Parkinson's and C. diff, and saying, what are we going to treat this guy with? Well, should we give him a gastric electrical stimulator? What do you guys think? Just go right to it. Go big. Let's maybe skip that one. We'll come back to choice A. We'll put a dot next to there and we'll come back to that one. So should we start erythromycin? Let's just group that with D as well. Well, so erythromycin, why shouldn't we start erythromycin? Based on, he's an old guy with C. diff. We probably wouldn't want to start an antibiotic. So a heart healthy, low fat and high fiber diet sounds like a really good choice, right? It sounds super healthy. Like this guy's going to be great. His heart's going to thank us. Then we start this. What do you think is wrong with that? Yeah, high fiber. Yeah, the high fiber content is when we'll get to kind of the gastroparesis diet, but you want a lower fiber content diet for this. Reglan. Should we start Reglan on someone with Parkinson's disease or known Parkinson's? Probably not. That's probably a bad idea. And so choice E is essentially, this is a gastroparesis diet. It's a low fiber, low residue. So we've gone through this question. We've picked out the salient important points. We've eliminated stuff based on just the stem. Even if you guys don't listen to anything I say, I just taught you a test taking strategy, I guess. So maybe you'll get one question right in your board. So hopefully enough to pass the board. So this is a low initiation, or excuse me, initiation of low fiber diet. This is a super busy up-to-date slide that we're going to blow past because it just summarizes everything I said in a very complex, up-to-date manner. So we'll go past that. So again, other things in the gastroparesis diet, things that most times I tell people, I get a lot of people in clinic that say, like, what should I do for this particular symptom or this whatever? Most of the time, there aren't specific diets, whatever you can tolerate. In this diet, you're actually avoiding fatty, acidic, and spicy foods can help. And you do want a low fat, low fiber diet for the reasons we talked about, because high fiber, high fat requires a lot of gastric squeezing, that trituration process. And if you can't do that, it's going to make your symptoms worse. It's going to acutely worsen your symptoms. And then you really want to focus on, I like to focus on a high protein liquid formulation diet. So whether it's your Booster, Ensures, whatever, I always say you should have one of these and sip on it throughout the day, or at least have one with each meal. That way you get your protein content without having to eat a lot of solids. Let's see. This is where we get pretty common, but this is a 45-year-old type 2 diabetes, postprandial symptoms, sounds like gastroparesis. Her A1C is off the charts at 10.1. And she already has peripheral neuropathy. So whoever wrote this question has essentially painted you a clear picture. Their stomach's probably not working very well. They did an endoscopy, which was normal, and a 4-hour gastric emptying study showed 26% meal retention. So is that normal or abnormal? 26%. Abnormal, yeah. So anything more than 10% is wrong, or is an abnormal gastric emptying study. So what would be the next beneficial step in this one? The reality is this person, as opposed to the last question, these other questions, A and B, you could consider that. And I think a lot of people I'll see people in the hospital getting put on Reglan. Like, that's pretty aggressive to just jump right to it. But they really need is improved sugar control. And the reality is you're not going to get immediate impact on their A1C, right? By just getting on it. But the rapid fluctuations in glucose can actually trigger gastroparesis flares. You have these symptoms of gastroparesis that get worse and get better. But if you actually have wide fluctuations, that can actually trigger a flare, and then these people get in the hospital. And so it's not necessarily even getting your A1C down. And in fact, actually getting your A1C normalized is probably not going to resolve it. It doesn't actually get rid of the gastroparesis. The damage has been done almost like a neuropathy, right? It's damage to the nerves are irreparable. Whether it's kind of mixed whether you can ever reverse it with this, and it's kind of been conflicting stuff in our data. But like I mentioned, it's really the acute hyperglycemia episodes and the fluctuations that you're really trying to control. And these are the medications, I mentioned this earlier, but you really want to avoid medications where their mechanism is delayed gastric emptying. So the GLP-1 analogs and incretin-based therapies. Again, like I said, I get a lot of people who just got put on these medications and they get referred to my clinic because they have nausea and concern for gastroparesis. It's just a medication side effect. So functionally, these medications, that's what they're supposed to do. It's how they work. So this is, I think, important for your, because you guys see you guys will probably have or will start someone on Reglan while you're in your medicine clinics. But this is a woman with gastroparesis. She's got typical symptoms. She's on Reglan and Zofran, but she's still having symptoms. What do you guys do if someone comes in your clinic and says, hey, I'm on Reglan, I'm still it worked a little bit, but now I'm losing the effect. What should I do? So choice A is saying a drug holiday. B, stop it. C, it's more common this specific question, I should say, the thing they're talking about here is the side effect that we're seeing, the licking and smacking of her lips. Do you guys know what that is? What is that? Sorry, was it? I think you all said it in unison, but it was almost too beautiful that you guys said it all together. So I think you, yeah. So I'll just go right to it. So drug holidays can prevent some of these neurologic side effects. Again, this is getting even back to the first question we asked about with neurologic, not necessarily the person with Parkinson's in the first one, but there are neurologic problems with these drugs. So drug holidays actually can reduce this. So this is kind of a busier slide. This is about metoclopramide or Reglan. So what you want to do is you start at a low dose and you can go up slowly. But what you really want to do is stop for a couple weeks every couple months. Technically, you're not really supposed to take this medication for more than 3 months. But if it helps, people do push the boundaries a little bit too. And so it's fine to do that. It's probably someone who would be in our clinic if they're going to take Reglan for that long. If tardive dyskinesia, which you guys all sang together, ensues, you really do need to stop the drug. The problem is that you don't want to do it. You don't want to just stop it. So this is an important point. If someone has this symptom and you're like, gosh, this is kind of scary, don't just stop the drug, because you can actually precipitate and worsen tardive dyskinesia. So you want to taper it down. Could take weeks to months. But even if you taper it, you might actually, even with tapering carefully, you might induce the symptoms as well. So we'll keep going for it. But anyway, that's tardive dyskinesia. Again, you just want to be careful. One of the drugs is actually super good and helpful. I use this in fellowship. When I say I told people to go to Canada and get this, or to order it from Canada, because we don't have it in the United States. It's called domperidone. It's actually pretty effective. I'm not entirely sure what the holdup is in the United States and why it has not been approved outside of emergency use, but this is fairly effective and safer than our conventional therapies, and better, compared to the next one listed, erythromycin and azithromycin. Those are useful. The time that I use erythromycin, I don't think I've ever used azithromycin, but erythromycin, you've probably seen us do this in the ICU acutely, but before we scope someone that's bleeding in the ICU, we'll give them a dose of erythromycin, sometimes Reglan, and it actually will clear within an hour. It actually will cause the stomach to squeeze and evacuate clot and blood. There's a reason why we do that. That's so we can actually see. So these are effective drugs, and they work fairly quickly. That's a different concept than just using it chronically, but that's why we do it. They are effective at clearing clot and things like that. And so you may see us ordering that. I'm not sure. Have you guys seen that in the ICU? We'll order, you'll think, what the heck are they ordering antibiotics for? It's specifically to clear the clot, because otherwise we'll go in and can't see anything. And then we'll be mad that we came in at 2 a.m. and we didn't do anything. So other things that we can do. So we have Reglan, we have domperidone, which is again nice, but you can only get it internationally. Antibiotics, those are treatments. The diet being probably the most important thing. But at some point we get to the point where we're needing a feeding tube. And this is obviously this will be in our clinic. You guys aren't going to necessarily be dealing with this, but you're going to be seeing a specialist at this point. We did this more common in our fellowship, where we'd actually trial a GJ tube or a nasojejunal tube, where you'd actually go down and either endoscopically or through IR and actually place the feeding tube in the jejunum and then see if they tolerate it. If they do that, then you can either do a surgical or IR GJ tube. So GJ tubes, essentially, as you'd expect, there's a gastric port, a jejunal port, where it is just a tube that you put in, and you can actually, they can be one step, but sometimes you'll do it in 2 steps, where you put the G tube in first and then come back and put an extension through. But this is really just so you can bypass the stomach. Just say, you know what, we're not going to deal with it. We're going to go right into the small intestine, and we'll just get your nutrition that way. Some of the other fun stuff, I know you guys probably all love gastroenterology, and I don't have to tell you how cool it is, but we do get to do stuff in GI. And some of the stuff that you can do, it gets crazier and crazier, like every month, some of the stuff they do. So you can do a transpyloric stent. What's pictured here, you can see, this is the antrum of the stomach. This is that pyloric channel the stent is going through. And this can kind of open this up. It can be used. It has had good responses, and it's better for people with nausea more than anything. But the durability of this is what I would call into question. You can't just leave this in forever. And stents do tend to migrate, meaning this will actually make its way through and fall into the small intestine. So whether this is truly durable or not is questionable. We don't do this routinely. This would be if someone really has no other options. But it could be considered and has been studied in small series. We'll move past this one. So getting on to the other advanced stuff we do in GI for this stuff. Have you guys heard of POEM before? Per oral endoscopic myotomy. So POEM is something that was is more commonly used for, this is an emerging use of POEM, but traditional POEM is usually for achalasia. So what you do is, it's actually a pretty intense procedure. What you're doing is you're actually tunneling, and you go down endoscopically, you tunnel it under the mucosa into the muscle tissue. And so you're doing this in real time, hopefully not perforating, you're literally just burrowing in between the mucosa and hopefully not going past the adventitia into the thorax or wherever you might be. And you're actually gonna go down, find the muscle layer, and you're actually gonna make a cut into the muscle layer. And what that does, it's a myotomy that will actually relax the muscle. Again, traditionally designed for achalasia, where that muscle is very tight in the distal distal esophagus. In this case, we're using that same technology. We're burrowing into the stomach and going to that pyloric channel, and we're actually cutting that muscle in the pyloric channel. Remember, that was one of the things that muscle does not relax very well in this pathophysiology. If you cut that muscle, it's kind of wide open there. So you're kind of fixing the problem by mechanically separating those muscles. So this has been studied. I think it's probably going to be used more commonly. POEM is not a common skill set, particularly GPOEM. We have one provider here in our group that does it, and GPOEM is within his purview if needed. But one of the studies that does look at this, and this is continuing to be studied, did show an increase in symptoms. I'm not going to go through all the details of this particular study, but it's kind of an emerging GI specific technology that you can do. But it's actually fairly safe, 100% technical success rate. Technically, you could also do this surgically, where a surgeon goes in and does essentially a pyloroplasty. But GPOEM being non or semi-invasive is becoming a popular thing that we're investigating right now. One of the things that you guys, I don't know if this will be on in your range of knowledge or skill set, but there's a thing called rumination syndrome. Have you guys ever seen this? Or what you'll see is someone who comes in, it's hugely tested in the GI boards, but I can't remember if it's something I had to know for internal medicine, but it's actually a psychiatric problem where someone will come in and they're like, I'll eat and I'll vomit undigested contents. And essentially what's happening is it's usually a behavioral disorder, and these patients will learn and they have this pathology where they just will, instead of the food bolus moving down to their stomach, they're actually like this huge intragastric pressure will push the food back up. So you actually have almost reverse peristalsis, where instead of things are going down and going to the stomach will actually increase its pressure. And what you're seeing in this particular waveform here, you guys are now, this is esophageal manometry here, but you can imagine as time progresses left to right, you can appreciate that this is a pressure, this is high resolution manometry, where green being some level of pressure, red being a high pressure system, and purple, pink being really high pressure. What's happening in here is food bolus is moving down here, or at least maybe not food bolus in this test, but essentially just the pressure of the esophagus is squeezing, and then something happens in the food bolus and we have a huge pressure increase and it actually goes back up. That's like super weird. You're not supposed to see this. But this is called rumination syndrome. And so it's a psychiatric diagnosis, kind of interesting. If you probably will never have to read esophageal manometry, but if you ever go into GI, it's something to know. And the thing that just kind of tips it off is like, you're not supposed to see purple. Like purple is like, this is just a high pressure system where you're just getting huge pressures moving food up. So this is one of the things that you can see. I'm not going to go into too much details in the small intestine. I know they were talking about mostly gastric in this particular lecture, mostly gastroparesis for that matter. But this is not again, it's simply not well understood. Same idea as though you're propagating muscle contractions throughout the small intestine to move things down. There are probably a fair amount of, and probably to some degree, a lot of functional bowel disorders that we see probably have some level of dysmotility in this system, but we don't have the knowledge yet to know what specifically and is there anything to do about it. I don't know if I have a slide in here about it. One of the other things that you guys might be fair game for you guys on your boards is dumping syndrome. Have you guys seen dumping syndrome yet? So what's that? Is that mixed up? Yeah, okay. So it's probably fair game. Almost invariably, you'll see this after a bariatric surgery. What's happening is you essentially have created a small stomach pouch. I don't have a picture of this, unfortunately, but so I'm just going to do hand gestures and just assume that you guys know what I'm talking about. But you have a small stomach pouch that goes right into your jejunum. You've essentially gotten rid of any kind of delaying, and the stomach delay is emptying for a reason, so you can help digest into more absorbable components. But now you have this small pouch that goes right in your jejunum with all these absorptive cells. And so the food bolus will go down, rapidly transit, and then with the huge sugar load or osmotic load, essentially, will pull fluid out from the plasma and essentially cause a relative hypotension. You'll get dizzy, you'll feel terrible. And you get flushed and you get diaphoretic. That'll be usually the classic board question that you might see. And it's almost always with a bariatric surgery. So what you have to do is the treatment is behavioral. It's eating slower, smaller meals to prevent that huge bolus of osmotic influences to prevent all the plasma from losing its blood into from losing the fluid shifts into the small intestine. So that would be a fair game question for you guys. There are some times where you can get, there's very rare things where you get hypoglycemic action during that too. But that's probably something that would probably be reasonable to know in the purview of gastric disorders. That's all I have to talk about today. Hopefully you guys maybe learn something, but at least understand that GI is complex and there's still a lot of things we don't know, particularly in the motility aspect of things, and what to do about it is kind of the next sphere. A lot of what you've seen and what I posted at the end there was GI is really turning these kind of advanced procedures in therapeutics. And, yeah.
Obviously, delay is voluntary. Is there any correlation with that since it is psychiatric?
Not, I mean, it would probably be a similar patient population, but not necessarily, they're not necessarily comorbid, or maybe not, they might be more increased risk strictly because they're in a psychiatric sphere, but not necessarily. what you're going to see here is it's more pediatric. I've never seen it actually in an adult, but this is more of a pediatric population that you're seeing that particular entity, which is, not an uncommon time for eating disorders as well. Younger, it doesn't always have to happen, but usually in maybe their teenage years, you might see eating disorders as well. But any other questions about this particular entity or any GI thing in general?
Is dumping syndrome only associated with people that have bariatric surgery?
Yeah, so for the most part, yes. There's times where, and I'll see patients that you'll get a gastric emptying study with native anatomy, and I'll say rapid gastric emptying, and they'll have symptoms that kind of sound like dumping syndrome. Whether that's truly it or not, I'm not sure. But for the most part, I would say yes. I would not call it dumping syndrome unless you have altered anatomy. But again, in theory, I guess if you are having rapid transit and you're dumping, a osmotic bolus into the small intestine, in theory, I guess it could happen, but not necessarily all very common that you'd see it. So the short answer is no, I don't think so. Yep.
We get a lot of patients who are admitted for like non-specific nausea and vomiting.
Yeah.
A lot of times like a viral thing.
Right.
Gastroparesis. We actually do order like patient care.
Yeah.
I think our initial reflex is to just start quickly.
Right.
We hope that they can start quickly. Seems like that's would be the right thing to do. You think it makes more sense to trial like IV erythromycin first, or
Yeah, I don't know if the reality is starting in the acute setting is probably, I think I think that when patients are getting better in the hospital, it's probably because you've rehydrated them more than anything. And you've probably treated their nausea in an IV format that they couldn't get at home. Reglan is an antiemetic, right? So that it might just be the antiemetic properties that you're truly getting, rather than, you might be helping their gastric emptying to a degree, probably to some degree, but I do see it started a lot inpatient, and if it, and that's usually in the interest of getting them discharged and not staying in the hospital for very long. If that's what it takes, it's fine. But my personal take on gastric emptying studies in the inpatient setting is that they have limited value. They have a pretty good negative predictive value. As I usually tell the residents and fellows, that if you're going to order one and it's positive, it doesn't tell me a whole lot. Like, I'm not going to label you as gastroparesis if you have a positive gastric emptying study while you're sick and admitted and feel like crap and you're not walking around. If it's negative, it rules it out. So it's got a high negative predictive value, not a great positive predictive value in the inpatient population. Usually if I have someone that I see in clinic post-discharge and they had a positive, I will repeat that in the outpatient setting and actually see. Because if you're labeling, you don't want to label someone with a disease that's probably chronic unless they really have it. And if you're not moving around, and most admitted patients, like, they're sick, they don't feel good, they haven't moved in a few days maybe, and GI motility is very important with being an ambulatory status. You have to walk to move around for the whole GI tract really to function properly. So to answer your question, if you need to use Reglan and it helps them, that's fine for a short course. I wouldn't give them like 3 months supply though at time of discharge. And then 2, gastric emptying study really is only helpful as a negative predictive value rather than diagnosing true gastroparesis. So, all right. You want me to keep this? You want me to keep this on?
Oh, yeah, you can leave it on.
Okay.
Dr. Cohen has
Dr. Cohen's coming in.
just for a few minutes to talk about.
Well, I'm already here.
You can start, Dr. Cohen.
What's up, everybody? I'm gonna rely on you to tell me that you can hear me all right?
Yes, we can hear you.
Sweet. All right, cool. So in the last 9 minutes, don't worry, I'm not going to teach anything. For our standpoint, exciting changes have been made recently in some of the consults, ways you consult ICU. So I'm going to share my screen real quick and grab, let's see. 1 second, guys. Cows. All right, cool. So Tina, is this looking good on screen?
Yes.
All right, cool. So real briefly, this passed like medical executive committee. It's now a live kind of requirement. So you'll see these posters going up. We now are required to be consulted on any patient that is going to an ICU or has an ICU level of care assigned to them, including in the emergency room, provided that they are admitted to one of your teams, as well as family and hospitalist, and they meet one of these criteria. And it's pretty obvious stuff. They're on acute BiPAP, they're getting worse, they're intubated, severe sepsis moving into septic shock, toxic ingestions, these kind of things. So nothing on here I think is surprising, but this just kind of codifies when at the latest we would want to be involved in anyone's care. You are all welcome to consult us earlier. You don't have to wait for this, but this at least provides some uniform consultation so that family medicine's not consulting us when they, give a liter of fluid. We're also not getting consulted then when the hospitalists have somebody on 3 pressors. So that's really it. I'll take any questions on it. And I will, this has been sent out to Curtis, and Tina, I can get you a copy if you want to disseminate it as well as all of your attendings. Dr. Youngblood was involved in the creation of this, as well as Dr. Swafford, myself, and a few of my team. Any questions on it that anybody might have?
No questions here. I wasn't too.
Cool. Just as a heads up, this does exclude cardiothoracic surgery, patients who are admitted to cardiology as a primary service, and anyone who would normally be consulted by surgical critical care, which doesn't really fall under any of our patients. But if you're on card service, we're certainly welcome to help, but it's not a requirement, at least up front. Cool.
So do we still go through like the 5010 consult number?
The question was, do they still go through the 5010 consult number?
Yeah, absolutely. So you can always contact us, as you know, 24/7 on 5010. If you're not getting a response, I would just call EROC and try to get a hold of us. That way it's pretty uniform. Eventually, and this will affect everybody, just speaking from the IT side, just like Tiger Text used to have groups, like you could text manager on call, we'll eventually have that where you can Tiger Text like critical care on call. But for right now, you got it, 5010.
Thanks.
I think that's it.
All right, cool. I'm going to go back to enjoying afternoon of Halo. We'll see you guys.
Thank you.
All right, bye guys.